morning, ladies and gentlemen, and selamat datang, selamat pagi in Bahasa Indonesia. My name is Leonardo. I'm the host for today's webinar. Thank you very much, Professor and doctors and all the fellow Indonesian psychiatrists and also resident trainees who have been very interested to participate in this wonderful webinar. Today, through the Indonesian College of Psychiatry, we would like to host the beautiful webinar regarding the clinical expertise in psychiatry, talking about the professionalism and learning path of a psychiatrist. So I think it's a beautiful morning this morning in Jakarta and also in the States. So, I think I would like to start our activity today with an opening remarks from Dr. Francisca Kaligi, Spesialis Kedokteran Jiwa Konsultan, who is the president of the Indonesian College of Psychiatrists. So, Dr. Francisca, please.
Okay, thank you, Dr. Leonardo, for your kind introduction. Good morning, everyone, and good evening for Dr. John, distinguished speakers, Dr. John and Dr. Agung, colleagues and participants. It's an honor to welcome all of you to today's webinar toward clinical expertise in psychiatry, professionalism, and learning path of psychiatrists. This event actually brings us together to reflect on the essential qualities that shape medical profession, which is scientific competence, ethical integrity, and a lifelong commitment to learning. As the field of psychiatry continues to evolve, so too must our dedication to developing clinical expertise that is both evidence-based and deeply human. Today's discussion will enrich our understanding of the professional standards expected to psychiatrists and illuminate the learning journey from training to practice that allows us to continuously grow in our role. The participants registered here to this webinar are psychiatrists, and some of them also early career psychiatrists, psychiatric residents, and also some general practitioners. I hope this session inspires meaningful dialogue, strengthen our shared values, and also support each of us in advancing the quality of psychiatric care. Thank you for being here, and I wish you all a productive and insightful webinar. Thank you very much.
Thank you very much, Dr. Francisca, for heart welcoming remarks for all the participants and also for the distinguished speakers that we have today. I think there is a great enthusiasm to participate in this wonderful webinar today. And also, I would like to thank also for the distinguished speaker, Dr. John, and also Dr. Agung Kusumawardhani, who allowed your time also in your busy schedules to participate in this webinar. So I think I don't want to take the whole time to talk with myself. So before we start with the presentation, I just want to highlight some few informations. So I will deliver this in two languages so everyone could understand. I think for the Q&A session, we will convey all the questions through the Google form. So we will share in the chat room the link to the Google form that contains also the your attendees link and also the link to if you want to deliver some questions. And we will have two presentations today, and this discussion will be conducted right after that. Selamat pagi, Prof. dan Dokter. Terima kasih untuk kesediaan waktunya bergabung dalam kegiatan webinar pada hari ini. Izin menyampaikan, Prof. dan Dokter, bahwa untuk kegiatan webinar pada pagi hari ini akan menggunakan bahasa Inggris. Dan untuk kenyamanan kita bersama, maka untuk pertanyaan, Prof dan Dokter bisa berkenan untuk mengisi dalam G-form yang akan kami bagikan di kolom chat. Jika sekiranya Prof dan Dokter ada kendala dalam menyampaikan pertanyaan dalam bahasa Inggris, Prof dan Dokter bisa menggunakan bahasa Indonesia di kolom di G-form yang kami bagikan dan akan kami bantu untuk proses penerjemahannya. Baik, kita akan lanjutkan untuk sesi presentasinya dan saya izinkan untuk menggunakan bahasa Inggris kembali, Prof dan Dokter. So, thank you very much, everyone, ladies and gentlemen, professor and doctors. So, we talk about the topics of professionalisms, and today's presentations from Dr. Agung and Dr. John, they both are inspiring people for me. And I would like also to introduce the Dr. John. Dr. John, I met him last August in India, in Guwahati, in the beautiful city of Guwahati. I had a very good impression regarding his presentation, and he is a geriatric psychiatrist actually, but he performed a really comprehensive and also beautiful presentation on how to be a professional in psychiatrist. So today, Dr. Finet John, he's the professor at the University of Texas Health at Houston, and he will present the presentation entitled From Novice to Expert, Deliberate Practice and Habits of Mind in Psychiatry. So, Dr. Finet John, good evening in the States and good morning from here. Can you hear me loud and clear as well?
Yes. Thank you, Leo,
Yes.
for this warm hospitality. I met Leo in August, like you said, and since then he got in touch with me and organized this wonderful webinar.
Yes.
Thank you, Dr. Francisco, for your warm welcome as well. And I have to say that it's truly an honor to share the stage with Dr. Gung, a national leader, an inspirational figure. And I hope to, although I know the speech is going to be in your language, I hope to glean as much possible, Dr. Gung,
Yeah.
from your talk as well. Most importantly, I'm making new colleagues in Indonesia, and that's a privilege. So thank you again, Leo.
Thank you. Thank you.
You want me to start sharing my
Yeah,
slides now?
please, please,
Okay.
please do.
All right.
Please do.
Perfect. Okay. Give me a second.
Sure,
This is
sure.
what,
Take your time.
this is where everybody gets nervous on my behalf. Okay. Is my slide clear?
Yes, yes, yes,
All
we
right.
can see it.
So
Perfect.
I changed a little bit from the title Leo had shown you, but it's basically where do we start? We're all at some point in our lives, we didn't know much about our field of psychiatry, but now we're on a journey. And that's what Dr. Francisco also said. We're all on a journey, whether we are faculty or a junior attending, an early psychiatrist or a seasoned psychiatrist, we're all on a journey. So to start off with, I want to tell you about this story. A story actually happened in 2009, Jan 15. US Airways flight takes off from LaGuardia Airport with 150 passengers at 3:26 in the evening. Within minutes, both the engines have been disabled because the Canadian geese, these birds, both flew into both engines. So the pilot had two choices. Either he could fly towards New Jersey and land in an airport called Titerboro Airport, or he could land in Houston, in Hudson. And that's exactly what he did. He landed in the Hudson, and everybody was saved. And people call it Miracle in Hudson. And so we know who the pilot was. This is pilot is Sully, but you know this is Tom Hanks. The actual Sully is Captain Chesley Sullenberger. And you could see here, this is no ordinary person. He had 40 years of flying experience. He was a former US Air Force fighter pilot. He had investigated many accidents and participated in many accident investigations, and he co-authored a paper on error-inducing conducts in aviation, and he was instrumental in developing and implementing crew resource management course at his airline. So this is somebody who was an expert. And so then they asked him, tell us about your secret. And so he says, One way of looking at this might be that for 42 years, I've been making small, regular deposits in this bank of experience, education, and training. And on January 15th, the balance was sufficient so that I could make a very large withdrawal. Dear friends, this is what is expected of us. This is why we all have to be experts, because one day there will be a patient who will need that sacrifice in terms of experience, education, and training, these deposits you made. And one day you will save that patient's life because of your superior expertise. And today we are together going to find out what are the secrets of experts? How do one become an expert? So we will look at the concept of expertise, how it applies to medical profession. I will make some connection to psychiatry, but it'll be more of a general topic. And it will describe various methods of acquiring expertise. And then finally, I would like to spend maybe 10 minutes about a study which discusses the attributes of a master clinician. So this is what Dr. Francisca was talking about. You start off as a novice, then by the time you reach your residency, you're already competent. And by the time you finish your residency, you're proficient. And then as we get into clinical practice and acquire more expertise, you find yourself an expert and then a master. So this is the aspirational goal. In the US, our Accreditation Council for Graduate Medical Education have set this as the goal for every single medical student. Is that true? Because the truth is that once you are removed from the robust learning environment of a residency program, a fellowship program, an academic program, you will lose your expertise. There will be what we call the silent tragedy of the erosion of expertise, which means that one could say that one is experienced, but if one is not deliberating on the accurate diagnosis, then one could have an erosion of expertise. So then we could ask ourselves, what is an expert? These are people who can pick things up or perceive more. They have a remarkable library storage of knowledge. They can quickly plan, reflect, and adjust their treatment plans, diagnostic plans quickly. They have social networks, cognitive networks, and that they use very effectively. And most importantly, they have the ability to draw on that practical knowledge and tacit knowledge, practical intelligent tacit knowledge to solve problems. So what is tacit knowledge? You could ask that question. So here it is. So the knowledge you learn from textbooks, which can be codified, which can be shared, the knowledge which is objective and technical. So if I write a small essay on a particular topic and send it to you, I'm easily transferring my knowledge about the particular topic, and it can be recorded and stored in any kind of form. So that is the explicit knowledge. Tacit knowledge is very different. It cannot be expressed easily. It is through our experience, and it's not codified, and it's difficult to transfer, and it's never, we can never record it. It's very much a personal issue, and experts have a lot of tacit knowledge. So if you see here, a novice is all about rules, an expert is all about intuition. A novice considers everything, an expert sees patterns. A novice is a detached observer, but expert is a part of the system. As I said, the novice has a lot of explicit knowledge, expert has a tacit knowledge. A novice studies everything very formally. There are classes and courses and laboratory sessions for them to learn things, but expert learns things very informally. So this is a great slide, which I love, is that novice gathers a lot of data, but still the diagnostic accuracy is very limited. Expert gathers less data, but they have very high diagnostic accuracy. That's because they follow some of the principles of developing expertise, which we'll discuss soon. So then we can ask ourselves, what is expertise in medicine? It is the knowledge and mastery of a specialized field of medicine leading to superior clinical application of their knowledge. And usually experts are limited to one domain. Either we know our areas of expertise could be limited to our specialties. And as I said, you could be an expert without having too much experience because you moved into the superior level of an expert using some of the techniques we're going to discuss in a few minutes. It involves both adaptive and routine expertise. A lot of the work we do could be called routine expertise, but adaptive expertise is this ability to apply knowledge effectively to novel problems in a domain without glossing over distinctive factors. So you could, what you learned in one domain, you can transfer it to another domain, and that is called adaptive expertise. But most importantly, the, the key attribute of being an expert is the certainty of reproducibility. An expert must be able to consistently perform at superior levels. So it is not easy to pick up how to study an expert. You may have to capture the expert performance. You may have to go and identify the underlying mechanisms, and then you have to sort of think how expertise is developed. So you could do simulation in the lab. You could do some field testing where you look at behavioral coding and performance metrics. You can go and check out the eye movements of an expert, subject expert in fMRI study. You could do biomechanical profiling. You can look at behavioral analysis, verbal reports, all this to what we call process measures. You can also look at the practice history profiles, and you can look at other training interventions as well. Yet it is not easy to sort of pick up what it is, the elusive thing called expertise. You could do physical exam skill tests in medicine, such as you could give a auscultatory exam, or you could ask them to identify skin lesions, or you could create a protocol where you give them a clinical case and ask the expert to think aloud. What are they thinking about? How do they make sense of this information you've given them? And then you could look at participants of this think aloud protocol and see how people are following certain thought constructs. You could also look at the weakness and strengths of such process, or you could do pathology slides and see if they will interpret them, or radiographs, or you could look at high fidelity scenarios like you do a patient encounter that's completely simulated and see how an expert deals with it. Or you can give an expert a patient history and see how the expert deals with that as well. But then when they really figure out the real experts, they realize a few things. These experts have a greater memory efficiency. They're able to store and retrieve memories quickly. They have a skill memory, which includes ability to develop exceptional memory skills, like long listed numbers. But they are also able to do chunking. Chunking means a lot of facts are grouped together, so that helps them to recall faster. They also have long-term working memory that is more stable to degradation than short-term memory. And then they also use shortcuts, but these are refined shortcuts, so they are always coming up with the right answer to those shortcuts. So this is the map of London. And to get around in London, you have to go in a black cab. That's how you see London in style. But if you become a black cab driver, you would have passed an exam called the knowledge. And for this, you have to memorize thousands of routes and know about 25,000 streets. So they are tested by the public carriage office. Usually people write 12 to 13 times before they pass this test called the knowledge. So two researchers studied the brains of these drivers. They wanted to know, if you are able to pass this test, then you are an expert of directions and visuospatial navigation. Will that show up in the brain scan? So that was the question. And guess what? It did. Your posterior hippocampus, as your time as a taxi driver increases from 0 months to 400 months, you see a direct correlation of the size of the posterior hippocampus and a correlation of decreasing size of the anterior hippocampus. And part of it is neuroplasticity. But in conclusion, the authors Catherine Willett and Elena Maguire says, From this, we conclude that the development of expert is possible with extensive effort, and this can be associated with neuropsychological and structural brain consequences. These effects can be positive and negative, with increased expertise in gray matter volume in some brain regions occurring in tandem with decreased performance of other tasks and decreased gray matter volume in neighboring brain areas. The study of taxi cab drivers in London was the first study which examined the expertise in a neurobiological sense. That has not been studied before. Since then, they've studied bus drivers, doctors, but they haven't got a similar striking results compared to the taxi cab model. So this is still a very powerful modality. So then let's come to this themes, the techniques which make people experts in medicine. One is a theme called knowledge encapsulation. Other is a theme called illness scripts. Third is situation awareness. Fourth is curiosity with meta reflection. Fifth is art of observation. And sixth, and the most difficult, is deliberate practice. Let's address each of them step by step. So what is knowledge encapsulation? And this is a complex concept. So it is a cognitive process by which detailed biomedical knowledge is reorganized and integrated into high-level clinical concepts through experience, enabling faster and more intuitive diagnostic reasoning. Our world of medicine is split into two different worlds. There is a world of bioscience knowledge, where people are learning about anatomy, physiology, biochemistry, pharmacology, pathology, microbiology. And then there is a clinical knowledge. You need both knowledge, both bioscience and the clinical knowledge to come up with the best diagnostic reasoning. Now, when you have a medical student, they are mostly on the bioscience knowledge, and they are very much going to be limited in the diagnostic reasoning. Whereas if you're an experienced clinician, they're going to focus more on the clinical knowledge, and they will use something called illness scripts. We'll come to it in a second. So that is knowledge encapsulation, that you can take these kind of possibilities, which are very simple, and you come up with a very complex clinical reasoning. So in his book, Complications, physician author Atul Gawande talks about a situation where he was met with an ER physician who was taking care of a young woman with some fever, skin redness, and skin induration of a lower limb. And the ER physician told Dr. Gawande, look, I'm just want you to just take a glance at this patient of mine. I'm going to send her home. I think she has probably skin infection, cellulitis. So this is the scenario Dr. Gawande is looking at. So it could be cellulitis, for which the patient is already getting treated. It could be osteomyelitis, which could be another differential, or it could be a very fatal condition called necrotizing fasciitis. The problem with the necrotizing fasciitis is that the moment you diagnose it, then you're on the clock. You have to call a surgeon. So Atul Gawande was actually a resident. So he called his attending, and it was late in the evening, early morning, 2 a.m. Attending has to come to the hospital. They have to get a pathologist also to do a frozen biopsy, because the moment you know it is necrotizing fasciitis, you have to do extreme debridement of the fascia and take muscle, everything which is affected. So this is a very serious condition. If they don't operate, then the patient could lose their limb, and if not, their life as well. So knowledge encapsulation is about combining lower level concepts of fever, skin redness, skin induration into higher level concept of necrotizing fasciitis. So let's look at a clinical history. We can look at a young man coming to the ER using drugs. He has chills and fever, accompanied by sweating, a feeling of prostration, shortness of breath. Physical exam reveals a toxin-looking young man having a rigor, temperature is 41, pulse is 124, blood pressure is 110/40. and he's got puncture wounds, his left antecubital fossa, which indicates drug use. So if a medical student is writing it, this is our medical student. As you imagine, the medical student is always going to go back to their biomedical knowledge. They're not going to focus too much on the clinical sense. So the medical student would assume, because of the potential drug use, the man must be using contaminated needles, led to gram-negative bacterial infection. This leads to activation of antibodies, fever reaction, shaking, chills, sweating, prostration, shortness of breath. It also may release endotoxins, leading to vasodilation. That is the reason for drop in blood pressure, possibly shock. But when an internist looks at it, here's a very simple answer. The patient develops sepsis as a result of using contaminated needles. So this is where we have to come to the concept of illness scripts. And we all have illness scripts in our head. We may not be able to write it down, but that's part of our tacit knowledge. It allows us faster, more accurate diagnosis. And also, we have it in disease-specific packets. It has a fairly regimented structure. There's something for epidemiology, some from temporal pattern, some statement about what kind of syndromes could be expected. It could have defining features, discriminating features. And if you have very refined illness scripts, that is a key to pattern recognition and problem representation. So it could have enabling conditions, have include the medical model, which takes into account physiology, biology, anatomy, chemistry, epidemiology, histology, but also it will have signs and symptoms and chief complaints as well, which is part of the consequences. In the book, every patient tells a story. Physician, author Lisa Santers says the basic science of anatomy, physiology, biology, and chemistry are linked to a patient at the bedside. Through very specific stories that doctors learn and eventually create. These stories, what researchers now call illness scripts, contains key characteristics of a disease to form an iconic version in our heads, an idealized model of the particular disease. The more experience a doctor has with any of these illnesses, the richer and more detailed illness script she has of the disease becomes. So the more experience we have learning this, then we'll have a. So here is acute onset of a recurrent painful monoarticular process in a healthy male. So it could be gout, it could be an infection, it could also be osteoarthritis. But if you look at that three kind of boxes on the left side, you see their predisposing conditions, age around 40, male sex, associated with alcohol use or use of diuretics. And then we have an idea about the pathological insult, which is abnormal uric acid metabolism, precipitation of crystals, and the clinical consequences are acute pain, single joint, usually first metatarsophalangeal joint and recurrent. That shows it could be gout. So that is the illness script. Same thing with bipolar disorders and borderline personality disorders. Bipolar disorders are 2.1% of the population. Male to female ratio is 1:1.1. The female to male ratio in borderline personality is 2:1. 10 to 20% mortality from suicide in bipolar, 8 to 10% mortality from suicide. So if you have a story with a pervasive course, abrupt changes in mood, which lasts hours, some degree of non-suicidal suicidal ideation, and transient psychotic symptoms, chaotic interpersonal relationship, and significant history of trauma. So non-suicidal self-injury is very common in borderline, NSSI, whereas in bipolar, it's less common, but they do have definitely episodic course and even psychotic symptoms. So this is the illness script for both bipolar disorder and borderline personality disorder. And the more we could sort of see that one is episodic, the other is pervasive, changes in mood is gradual in one, abrupt in the others, less non-suicidal self-injury in bipolar, more in borderline. Family history is more in bipolar, may not be as common in borderline. Chaotic interpersonal relationships, history of trauma is more in borderline. These are two different illness scripts, and then we can figure out the right diagnosis. The next technique is called situation awareness, which includes the perception of the elements in the environment within a volume of time and space, and comprehension of the meaning of these elements and projection of their status in the near future. This is called situation awareness. So you perceive, you comprehend, and you project into the future. For an expert, situation awareness or SA is fast, effortless, complete, and includes greater comprehension and projection. But if you're a novice, it is found to be extremely demanding and they're full of errors and is incomplete. So situation awareness differentiates an expert from a novice. And there are so many other themes here, right? Individual factors like goals and preoccupation and experience and training, environmental factors. But the truth is that once you perceive and you comprehend and you project, you have to make a decision and then you have to make an action. So that is the whole future of your performance depends on what decision you made based on your situation awareness. So again, I'm coming back to that story of Chesley Sullenberger, Captain Sullenberger. He perceived it, he comprehended it, he projected into the future because he had been making those deposits. The next theme. So we talked about knowledge encapsulation. We talked about illness scripts. We talked about situation awareness. The next theme, which helps us to become an expert, is curiosity, the impulse to seek new information, experience new possibilities, which is a basic human attribute. Curiosity will help us to learn more about personal aspects of a patient, help us with data collection. It could be a learning opportunity. It could help us trigger research. But the culture of medicine does not allow for most of us to practice curiosity. There is a lot of focus on doing test after test after test. It is not really patient-centered. And the more you focus time on a patient is seen as unrewarding and non-prestigious. And then if you have emotions like anxiety or irritability or depression, you're not going to be curious. Or if you're overconfident, you're not going to be curious. Or if you're very, very busy, you're not going to be curious. But then if you're curious, it promotes the development of perceptive, compassionate, wise healthcare providers. It can help us develop respectful relationship with our patients. It makes us current and open with the medical skills as our medical knowledge is evolving rapidly. So part of being curious is also being aware of our own thinking process. Because when we are reflecting on that, we will know whether we have biases and we could, adapt to new learning methodology. This story is about an accountant who'd been suffering from extreme fatigue and cough. She was not able to work. She met many, many doctors. They were trying to give her multiple medications. None of it worked. She was getting frustrated because she was so tired. So one day, because of this cough, she called the pulmonologist's office and said, I need an urgent appointment because I have tuberculosis. They got so scared and they invited her to come in for an immediate appointment. While she was talking to the pulmonologist, a pulmonologist noticed that her skin was looking like the tan of a prominent American president, John F. Kennedy. Now, you all know that John F. Kennedy had Addison's disease, and that's exactly what the patient had. So one of the themes is about the art of observation. When we observe our patients, when we observe a situation, it has to focus our senses and engage our environment. We all have subconscious filters. You have to go beyond that, and you have to pay attention to details, and you have to prioritize the critical, important, and urgent. So here is a picture. Do you guys see anything here? There is something here, which is a gorilla. This CT image of the chest contains an embedded gorilla. I am not doing any trick. You can see it here. 50% of the radiologists, 75% of the radiologists missed it, So they were not even imagining such a gorilla would happen in the CT scan. And they were no better than people who had no training in radiology. Whereas if you gave them an audio, they're so much better than people who haven't been trained in radiology. So we're coming to the last part of the themes of expertise, which is basically called deliberate practice. This is from Malcolm Gladwell, who wrote in the book Outliers. The 10,000 hour rule says that if you look at any kind of cognitively complex field, from playing chess to being a neurosurgeon, we see this incredibly consistent pattern that you cannot be good at that unless you practice for 10,000 hours, which is roughly 10 years if you think about 4 hours a day. Now, you know that Malcolm Gladwell is a journalist. This is not his original piece of research. The research is done by a professor at Florida State University called Anders Ericsson. He talked about deliberate practice involving practicing alongside a great coach or a teacher. That is the key to being an expert. So deliberate practice is years of effortful, focused practice on authentic task in an environment of continuous feedback and support, accompanied by self-reflection and correction. That is deliberate practice. And so Anders Ericsson says the development of genuine expertise requires struggle, sacrifice, and honest and often painful self-assessment. There are no shortcuts, and you will need to invest that time wisely by engaging in deliberate practice, which is the practice that focuses on tasks beyond your current level of competence and comfort. This is very important, that always we are trying to be very comfortable. We don't want to feel discomfort at all, but that is something we really need to be